So, good morning, everyone. First of all, I'd like to thank to all the speakers, especially Dr. Douglas Koch, who agreed to be here with us. He's one of the most acknowledged ophthalmologists practicing in this area of interest, that is biometry and cataract surgery. So, big, it's a great that we have him here today. We'll start our session with an article presentation that's going to be shown by Fernanda, as Dr. Chamon already said. She is a fellow of our sector, and this is a great article. I think everyone will take something from it. And Fernanda, please, if you may start.
Are you listening? So, good morning, and I'm very glad for the opportunity to present the article today in such a special meeting. And I have no conflicts of interest. And the article I'm going to present has the title Accuracy of Intraocular Lens Calculation Formulas. It was published in Ophthalmology in June of 2018. And the authors are Ronald Mells, Jack Holliday, and William Cheng. Dr. Mells and Dr. Holliday are supported by the Kaiser Permanent Community Benefit Research Grant, and Dr. Holliday is, of course, the developer and president of the distributor of the software of Holliday Formula. So the prediction of refractive outcomes after cataract surgery has steadily improved, but yet there is still considerable debate about which formula provides the most accurate refractive prediction. So they asked four main questions for the study. The first one is, of the currently popular IOL calculation formulas, including Barrett Universal 2, Huygens, Hoffer-Q, Holliday 1 and 2, Olsen, and SRKT, which is the most accurate when evaluating the error in predicted postoperative spherical equivalent, including eyes of all ocular dimensions. The second question is, what is the accuracy of the various formulas when evaluating short, medium, and long eyes? The third one is, what is the extent of bias within each formula for different biometric dimensions of the eye, including anterior chamber depth, axial length, corneal curvature, and lens thickness that lead to imperfect predictions. And the last question, sorry, not good. The last question, does the use of the one-Koch axial length adjustment for the Huygens, Hoffer-Q, Holliday 1, and SRKT formulas in long eyes lead to improved outcomes? The study consisted in a retrospective consecutive case series, including patients from this medical plan who underwent uncomplicated cataract surgery performed with clear corneal temporal incision by 145 surgeons. And these two different kinds of IOL were implanted, the SN60WF and SA60AT, both from Alco. And the surgeries were performed between July 2014 and December 2015. The selection criteria of the study included patients with 21 years old or more, and all of them were submitted to LensStar 900 biometry with the selection of more than 37,000 patients. After that, they excluded patients with history of corneal disease or corneal surgery, as well as patients with lens thickness with less than 2.5 millimeters or with data missing, keratometric cylinder over 4 diopters, or data quality issue. And from these cases with valid biometry, they also excluded the patients with unavailable postoperative refraction between 2 weeks or 4 months after surgery, as well as patients with best corrected visual acuity worse than 20/40 or not recorded. So from this, they included only one eye from each study subject, choosing the eye with better visual acuity if it was unequal, resulting in 5,200 eyes to SA60AT and 13,301 eyes with SN60WF. The spherical equivalent formula predictions and length constant optimizations were performed with Barrett Universal 2, Hue Radial Basis Function, Olsen, Huygens, Hofer-Q, Holland 2, and SRKT. The Hue RBF method has an outlier detection features that excludes certain patients, and in this study, more than 800 patients would be out of the bounds, and moreover, this formula is intended for the use only in cases where the post-operative target outcome is plano. So from this, the authors estimated that approximately 15% of the patients of the study would be excluded, and it would make it incomparable to the other formulas. So for these reasons, the Hue RBF was not included in the final analysis. For Huygens, study used only the outcomes for the single optimization in the final analysis to compare the formulas on a more equal basis. And they used this ULIB constant length optimization suggested to compare the constants in the end. The study populations were separated in 3 subgroups by axial length, with short eyes from less than 22.5 millimeters, medium eyes, and long eyes with more than 25.5 millimeters. And because many of the theoretical thin lens optic formulas have been associated with hyperopic outcomes in long eyes, this study of Wang and including Dr. Koch as an author suggested that the axial lens measurement in these eyes should be adjusted to offset this potential error. So to evaluate this modification for eyes longer than 25 millimeters, the authors of this study used the recommended one-center regression formula displayed here. The statistical comparisons between formula absolute prediction error were performed using repeated measures analysis of variance with Friedman test, with Wilcoxon sign rank post hoc analysis, and Bonferroni correction. Going to the results, this is the table with the demographic characteristics of the patients. And so almost 60% of the patients were female. And here the distribution of the patients in the racial distribution is representative of the diverse population of Northern California where the study was performed. And in the other features, in the groups of both, everything was similar. The optimized constants are shown in this table, and they separated them in a distinct result when it was applied the one-call correction, as shown here, like one call, and when it was used the ULIB website suggested constant for each formula. These are the outcomes of SN60WF, and they ranked the formulas by standard deviation. The Barrett formula showed the lowest standard deviation from the spherical equivalent predicted, followed by Olsen and Huygens. In this histogram, you can see the percentage of eyes within prediction error groups. So in red, the percentage of more than 1 diopter of error, in yellow ranging for 0.75 to 1 diopter of error, and in blue, the lowest error until 0.25 diopters. So this shows that the errors in Barrett formula, the first one here, for example, had the lowest percentage in the group of the more remarkable errors. And this other table shows the outcomes of the other IOL used, also sorted by standard deviation and with similar results, with Barrett showing the lowest standard deviation, followed by Olsen and Huygens. This other figure shows the mean absolute error in diopters here, going the hyperopic direction or myopic direction in all of the groups. So in blue are the short eyes, in green the medium, and in red the long eyes. And so here, the adjustment with a one-call correction showed an improvement in holiday 1 here with the correction and without, and Hoffer Q with the correction and without, but did not significantly change the prediction error for SRKT and led to worse outcomes with Huygens, with an overcorrection of this with the one-call modification. With the other lens, the SA6080, there was no difference in Holiday 1 and Hoffer Q, and it was worsened in Huygens and SRKT. But in general, the one-call adjustment caused an overcorrection of hyperopic outcome long eyes to result in myopic errors in this study. Going back to that same chart, the Barrett showed the lowest mean absolute error, prediction error for short eyes here, and the Hoffer Q had the greatest. For long eyes, on the other hand, the Olsen had the lowest mean absolute prediction error, and Holiday 1 and Hoffer Q had the greatest. This other figure illustrates the variation in the prediction error within different IOL powers for SN60WF, as well as the frequency distribution of the IOL implants. So you can see here that where most of the IOLs implanted are concentrated, the formulas had small variation, with much more variation between formulas in the extreme values of IOL diopters. And then they displayed some graphs represented the mean of the variation in prediction error for some ocular dimension. This first one, we have the variation with the axial length here. And concerning the keratometry, the SRKT in the black line in particular is adversely affected by eyes that have flat here or steep corneas, much more than the other formulas. This third figure demonstrates that Hoffer Q in green here and Olsen formula in purple have significant bias with varying anterior chamber depth in opposite directions, whereas Huygens formula that is shown in yellow here shows little deviation in the prediction error. On the other hand, the same Huygens is the formula most affected by variation with the lens thickness showing here in yellow. In these four ocular biometric parameters, the Barrett appears to have the least bias of the formulas. You can see here in red, maybe it's not so clear to see, but here is the variation with axial lens, here with keratometry, here with anterior chamber depth, and here with lens thickness. So going to the discussion, the Barrett and Olsen formulas had the best outcomes in terms of accuracy of postoperative spherical equivalent both of the IOL models and performed across a range of axial length and biometric dimensions. Between lengths of 23 to 25 millimeters, all of the formulas gave results very small, within 0.1 diopter of predicted spherical equivalent. So the major reason for the difference between the formulas is their performance outside this range in the extremes. And surprisingly, contrary to the expectation, Hoffer Q had the worst performance in short eyes for both IOL types, which was consistent with these two other studies that are also recent with similar results. The study limitations now. So although the ranking of the formulas were similar between the two IOL models evaluated, they caution that these results may not be generalized to IOL models of different designs. A notable limitation of the study was also the significant number of patients that did not have a refraction recorded during the designated postoperative period. So some of these patients saw an optometrist outside of the health plan, but the authors also suspected that some of them did not return for the normally scheduled examination because they were highly satisfied with their refractive outcome without spectacles. So if that supposition is true, they suggested that the study may be biased in terms of slightly worse outcomes for the various formulas than if all patients were included, but this would not change the relations between the formulas. And the one co-modification of axial length for long eyes appears to overcorrect and result in myopic errors in this study. But as they used the one-center study regression modification, they suspected that if they had used the the center study regression, the overcorrection might have been slightly less. Like they say, the one-center study regression is a more aggressive modification. So they suggest a further exploration in further studies about this. Thank you.
You're mute, Felipe.
Sorry. Thank you, Fernanda. It was a great presentation. I think this is a very interesting article, and I'd like to ask Dr. Douglas Koch some questions. First of all, your general comments on this article, and also why was the single center one Koch correction used for these calculations? And also, if you'd point out a take-home message for our attendees, what do you think we can extract from this paper?
First, Fernanda did a fantastic job presenting this paper. She really covered the material very, very accurately and clearly. I thought it was great. The Wang-Koch modification, we came up with that. It was actually Li Wang's idea, and then we worked on it together. We came up with that because we were seeing hyperopic results. And our goal in creating it was to prevent hyperopic results. You don't want to take a myope who's been myopic all their lives and leave them +1. So our goal was to help people prevent any postoperative hyperopia. And the Barrett formula will leave some patients hyperopic, whereas our modification rarely does. On the other hand, the Barrett is centered more along zero correction, as opposed to ours, which is about -1/4, which is exactly what I would have expected. We have subsequently modified our formula and published that with a less aggressive formula, both for our formulas for the Holiday 1 and for the Holiday 2. And that puts it right on, sort of on par with the Barrett. And, but still in our practice, we still use the Holiday 1 because I just don't want to leave these patients hyperopic. And if they're -1/2, they're happy. If they're +1/2, they might not be happy because their near vision is so terrible. This study is interesting for a lot of reasons. First of all, the number of patients. One of the things in a study like this is who is doing the refractions? How accurate are these refractions? It's a real world study, and as such, it's interesting. One of the things about the Barrett formula in this study is the Barrett formula knew exactly the parameters of those Elcon lenses. Those Elcon lenses, like all lenses, have curvature on the front and on the back. And as they change power, particularly the SA60 series, the front may not change for 5 diopters. They keep changing the back, and then they'll change the front and keep changing. So by knowing exactly the lens parameters, you're going to have an advantage and be more accurate. Had the other formulas had that advantage, I don't know that you would have seen the difference. I think the other thing that's interesting is that look at that accuracy, 80%. You know, people keep standing up on a podium and saying, I'm 90% with a half diopter, I'm 91%. But I don't see any published articles that report 90% or better. So there's still a lot of work that we need to do. Let's see. As far as the Hoffer Q, I agree with their findings. I've not found that to be a useful formula. And the Olson formula, I think, was modified since they did that study. He put in what was called a C constant to come up with a better way of determining the effective lens position. Whether that would have made the Olson a little bit better or not, I don't know. So, and I think it's interesting about when you think about out of bounds with the Hill RBF. Dr. Hill doesn't want his formula analyzed when there are for data that are not within that big net of data that he has in his formula, and that's very understandable because, you know, his formula would have to guess what that IOL would be. But all of the formulas really go out of bounds, don't they? I mean, none of these formulas are optimized for a 20 millimeter eye or a 29 millimeter eye. So all these formulas in a way kind of go out of bounds. So I think those are the things I'd like to point out. And I'd love to hear other comments.
So as always, perfect. You know, this is the real take-home message of the article. Fernanda did a superb job. I must agree with you, and congratulations, Fernanda. And I think with Dr. Koch summarizing the article gave us what we need from it. We should move on, Felipe. It's your job to make us to be on time.
Of course. So we'll move on for Professor Koch lecture.
Okay.
Professor Koch is, as I have already stated before, he is one of the most recognized and does a brilliant job on this area. For those who don't know, Professor Koch is actually in Baylor College, Professor Koch.
That's correct.
And well, you'll see his name in many articles that we actually discuss in our meetings also. And with no further ado, please, Dr. Koch.
Thanks, Felipe. Can you hear me clearly? Good. Okay, great. So let's talk about toric IOLs. Well, what do we know about our toric IOL selection and what we do with our patients? First of all, for the level of correction that we should do depends on the patient, of course. And I like to get most patients, if they really want great uncorrected vision, under a diopter for a monofocal IOL. But for a multifocal IOL, I think we have to be less than a half diopter of astigmatism. You remember our old friend, the conoid of Sturm here for astigmatism, where there is not one single point of focus. There are two lines, and then there are all these ellipses, and then the circle of least confusion. But multifocal IOLs have sort of the same thing. Instead of having a single point of focus, they have 2 points of focus, or maybe even more if it's a trifocal IOL. And if you combine those and overlap them, and I've tried to show you, there's the conoid of Sturm, and you overlap a multifocal IOL on top of it, you can see that it blurs the circles from the amount of blur increases. So treating astigmatism, I think, is extremely important, particularly in these eyes. And there was a study by Hayashi in Japan in 2010 where he took the Restore 3 diopter and he added a half diopter of astigmatism, and the vision dropped from 2020 to 2030. So it's a significant impact. So we got to get less than a half diopter. What about surgically induced astigmatism? I operate temporally with a 2.4 millimeter incision, and we evaluated 50 patients, And in 1 year, the mean astigmatism that we induced was 0.1 diopters, measuring the anterior cornea. And I'll come back to that about the anterior cornea. But there was a big range. And one patient had a surgically induced astigmatism of 0.8 diopters. Now, these were measured with a lens star. Was that truly induced astigmatism? Or was it just errors in a measurement? You know, that's such an important factor when you're measuring these low amounts. So I use 0.1. You can calculate it using Dr. Hill's SIA calculator. And Adi Avalafia has created a calculator for calculating your surgically induced astigmatism that's going to be posted on the ASCRS and ESCRS website very soon. So I like to look at least 3 data points. I actually do IOL Master 700 and LensStar. And I use topography primarily for alignment to make sure that what I see visually on the topography lines up with the steep meridian that I get from the IOL Master and the LensStar. Glasses sometimes, interestingly, can give you clues, particularly if there's less with the rule astigmatism and the glasses are more against the rule. I think it may give us some clues of maybe about lens tilt, but I do pay attention to that. But if I don't have clear answers, I will remeasure my patients. And if I still don't have clear answers, I tell them that I think we should just wait, reevaluate them after surgery, and then we can decide what to do. So here's a patient who came to me for pre-op. You can see the LensStar 4334, 2 diopters of astigmatism. So you're thinking a toric IOL, of course. But the IOL Master did not give me any K readings. And in fact, if you look at the reflections of the Myers, you'll see that there's one missing right there. Can you see my mouse, by the way? Okay. So this patient had seen me 3 months ago, and here's the Galilei, which is a little unusual. But look at the Myers. Those look very good. And his corneal power here was 44.6 as opposed to 43.34. And his astigmatism on the Galilei was 0.1 instead of 2. So we looked at the Myers for the LensStar, and you can see all the distortions down there in the same spot that the IOL Master was missing data. And we treated the surface, and 6 days later, everything looked good. And he got a standard EDUF. He had no astigmatism. So you need more than one measurement. You can't rely on one measurement, and you've got to verify the quality of your raw data. And every one of you should be looking at your raw data in order to be sure it's accurate. You can do it 2 ways. You can look at the reflections of the Myers. You want to see this nice, sharp reflections of the LED lights. And this is, of course, poor quality. Or you can use standard deviations. Warren Hill has said that a standard deviation on the LensStar of over 0.3 diopters for the flat or steep meridian, or 3.5 degrees for the actual meridian itself should indicate that there may be variability. How do we factor in the posterior cornea? We know the posterior cornea creates astigmatism, that in most eyes, the posterior cornea is steep vertically, and it creates against the rule refractive astigmatism. So we can incorporate the posterior corneal astigmatism into our toric calculations 2 ways. We use regression formulas, or we can actually measure the posterior cornea and use that value. So we know that for patients who have with the rule astigmatism on the front of the cornea, the amount of this is the increasing amount on the anterior surface. This is posterior corneal astigmatism, and it increases up to 1 diopter on the posterior cornea as you get steeper on the front. So that's a big effect. But on the posterior cornea, when the eye has anterior corneal astigmatism at 180 against the rule, the amount of posterior corneal astigmatism does not increase as the amount on the anterior surface increases, but it can be as large as a ½ diopter. So the regression formulas we have are the Baylor nomogram, the Barrett toric calculator, Avalafia Koch, Johnson & Johnson's toric calculator, partially based on the Baylor nomogram, and then the Alcon toric calculator, which is also the same as the Barrett. And all the reported studies show about 80% within a ½ diopter. That's a familiar number, isn't it? It's the same number that Fernanda reported in the Mellis study. It's interesting we seem to be stuck around there. And the problem with regression formulas, of course, is there's so much variation. And here's the regression line, but look at the scatter of individual patients who don't fall on that line. So, and of course, in complex eyes after LASIK, that relationship between the front and the back is lost. And it's really, of course, challenging to measure even the anterior curvature in those eyes. So what about direct measurement of the posterior cornea? Does that make our outcomes better? We can do it by tomography, which is thickness-based, Scheinflug devices, Pentacam and Galilei. There are no studies that show any benefit of directly measuring the posterior cornea with the Pentacam or the Galilei compared to our regression formulas. What about OCT devices? The Avante, which also can give you astigmatism, the Argos, the 08 2000, and of course the IOL Master 700, which is now giving us total keratometry. And it does so by using swept source OCT in combination with the anterior corneal measurements from the LEDs to give total corneal power. Well, there's also another way to measure posterior cornea, and I think many of you know about the Cassini that uses these color light emitting diodes for the anterior corneal surface, but these 7 white LEDs can be used to measure the posterior surface because they detect the second Purkinje image. And here's a magnified view of that, anterior and posterior. So you can measure the position of those LEDs and predict posterior corneal astigmatism. And they're about to introduce an even new version of this, which will be much more extensive. It will be very interesting to see. Well, there isn't much data yet on measuring total corneal power. Using total corneal power, Graham Barrett in post-LASIK eyes reported just 16 eyes. And he reported that if you use his true K toric prediction from the anterior only, he has 68% accuracy. If he used the within a half diopter here, and if he used the measured posterior corneal astigmatism, an increase from 68 to 75. So that's kind of interesting. We've looked at that in our data, and we measured the posterior cornea with the IOL Master 700. We saw some benefit in eyes that had against the rule astigmatism, but interestingly, we did not see any improvement in eyes with the rule astigmatism compared to the standard formulas. So direct measurement is getting better. Not really there yet, and I think we have a little work to do to figure out how to maximize that. Of course, we know we have to mark our eyes very carefully. 10-degree misalignment results in a complete, actually, a 33% error in astigmatism correction. And what I like to do is make a pre-op drawing if there are prominent vessels, or when I mark the patient, I sit the patient up, I mark at 3 o'clock and 9 o'clock, and then I reposition the patient and note the misalignment of the marks. So here is where ideally I would like to make my marks on a patient. And so I'll go ahead and make marks. Here's one mark and here's the other. Notice they're not exactly at 180. Well, that's not a surprise because it's very difficult to get them right on that accurate. So by taking a drawing to the operating room that shows me exactly where those marks are, it gives me a lot of precision. Of course, we have these wonderful high-tech options. We just got the Zeiss Callisto, which is wonderful, and the Alcon Varian. But we published that with the amount of error we got for automated versus this very obsessive compulsive manual marking was the same, 3 degrees or less than 3 degrees, and all of the eyes were less than 10 degrees. So I think you can do manual marks and get equal results to these automated systems. The automated systems are admittedly faster and easier, and they're cool as heck, but not necessary. I think we'll go to those over time, but not necessary. What about post-LASIK eyes? This is kind of an interesting group of patients. Obviously, we just published this in JCRS, and we have found that you can use toric IOLs with good accuracy if you meet 3 criteria. Regular bow tie astigmatism on the anterior surface within the central 3 millimeter zone, and whether it's myopic or hyperopic LASIK. If you've got something pretty good within the central 3 millimeters, that's great. The difference between corneal astigmatism magnitude between the IOL master and the lens star, or it could be between the IOL master and your topographer, between 2 devices is less than or equal to 7.75 diopters. And here, for example, it's less than 0.75. Criterion number 3, the difference in the astigmatism meridian between two devices. In our study, the lens star and the owl master, less than 15 degrees, and here's 13 degrees. If those eyes met all three criteria, and the way I factored in the posterior corneal astigmatism on these eyes was, since the anterior cornea doesn't tell you what the posterior corneal astigmatism is, so I estimated it at 0.3 diopters with the rule, and the target was to mildly overcorrect eyes who had with the rule astigmatism, full correction of oblique astigmatism if the eyes had against the rule astigmatism, mild undercorrection if they had with the rule. In other words, leave them with a little bit of with the rule. And if they're against the rule, mildly overcorrect them. And amazingly enough, when the corneas met those three criteria, the percentage of eyes with refractive astigmatism less than or equal to a half diopter was 80% in the post-myopic eyes, 56%, and 84% in the hyperopic LASIK eyes. So that's pretty exciting. What about keratoconus? Well, keratoconus is, let me go forward here. Keratoconus is obviously a real challenge. The front's so irregular, and how do you measure and understand the back? We use toric IOLs if the eyes are stable. You have to document that. If the topography is fairly regular in the central 3 millimeters, the patient is not going to be wearing a contact lens. And if you can get some glass, know that their spectacle correction with the astigmatism correction before the cataract got very bad, gave them good vision. And if that correction is the same as the topography, I think you can use them. And that's true also for radial keratotomy, by the way. But I think we need a better way, and I think ray tracing is going to lead us to a much better way to do these corrections. What about ray tracing? Well, I think ray tracing is very interesting. The only formulas that use it that are commercially available are the Olsen and the Oculix from Rolf Preussner in Germany. And ray tracing incorporates aberrations and tilt of the IOL. And so when you have irregular corneas like this, it takes into account all of these irregular areas to try to predict the corneal power. And it also takes into account that the IOLs have different asphericity. So these formulas have built into them, like the Barrett did, the asphericity, the curvature on the front, the curvature on the back, and of the various designs. We just published a study in ophthalmology that showed that if you measure the axial length in separate units rather than a block, you might be more accurate. Remembering that what we do now with our biometers is we measure the entire length of the eye, and we convert the light that comes back with one constant back into the length of the eye. But if you take each little segment of the eye and segment it so that you have a different refractive index for the aqueous, a different one for the lens, and a different one for the vitreous cavity, this is going to, I think, make a lot more sense, particularly for those eyes that the Mellis study, as Fernanda pointed out, either long or short, where the formulas don't do as well. And I think we can customize measurement of axial length. And we showed, for example, here's the Barrett formula. This is the standard results of the Barrett. Notice it falls off in these eyes that we measured, in eyes that are less than 21 millimeters, and a little bit more off in eyes that are over 32 millimeters, admittedly very long. If we segmented the axial lengths, we improve the accuracy a little bit. So it's interesting to see how that might play, but ray tracing will take that into account. But the limitation of ray tracing, and the reason that the Olsen didn't do that better, as we talked about, is ray tracing does not have a magical solution to predicting the effective lens position. So we're still in a situation where we're trying to guess through our own little internal formulas in these formulas how to calculate the effective lens position. So the outcomes of the ray tracing, just as Fernanda showed in her study, are not better than our best formulas. But for irregular corneas, where it takes into account all that irregular topography, I think they have great potential. So another really exciting advance is the AcuFocus IC8, which you can put inside the capsule. And here's an example of the eye after radial keratotomy from Dr. Kent. And that really helps to cut down on the distortions. And of course, you have in Brazil the extra focus sulcus IOL from Claudio Trindade, and there it is, the mortual lens. And here's a post that Bruna or a photo that he sent to me that I think is really nicely shows that lens. It's a sulcus lens, which is interesting. I'll be interested to know if you have experienced it. Well, what do we still need to do? We need to do better, as I mentioned, in our eyes with irregular corneas and those that have had any kind of form of endothelial replacement. We need, for these eyes, we need not only better posterior corneal measurements, but I think we really need better anterior corneal measurements, as we've discussed. We need to factor in IOL tilt. And this Rodrigo, our fellow, was very involved in this study with us. And we used the IOL Master 700 swept source OCT. And unfortunately, these are images from the IOL Master 700. You cannot get these out of the device. You have to send the data to Germany. So it's not available for clinical use. But we found that the crystalline lens tilt in the eye was on average 3.7 degrees, up to 7 degrees. And there's of these 6, it measures in 6 different meridians. And here you can see the meridian where there's the greatest amount of tilt. And in fact, this is horizontally, right through horizontally. This is the nasal side. This is the temporal side. And you can see that the nasal side of the lens is more anterior than the temporal side of the lens. And when you go to the IOLs, notice that there's more tilt with the IOL, and it gets even higher, up to 10.7 degrees. And so you think, now why does the crystalline lens tilt it? If you look at the eye anatomically, there shouldn't be a tilt, but remember, where's the fovea of the eye? The fovea is here, over on this side. So in order to bring the fovea into view, the eye has to tilt, and there's that tilt of the lens. And that's why we also, the angle kappa, or the corneal vertex, is also nasal to the center of the cornea. It all fits together. So it's nasal anteriorly. And that, what does that do? It actually creates more against the rule refractive astigmatism. So we now have the lens tilt and the posterior cornea creating this. So can you predict IOL tilt from the pre-op lens tilt? We measured 65 eyes. There they are in these 65 that were pre to post, 3.6 degrees up to 6.7, 4.8 degrees up to 9.3. So that's a lot of tilt. And the tilt direction and magnitude were very accurately predicted by the preoperative measurement. And this is the regression line for the magnitude. And we have an R squared of 0.5, which is really quite good. And there's one of the representative eyes pre-op and post-op. And there's the IOL with the same tilt. Again, I want to thank Rodrigo, who did so much work in collecting the data for that. So Mitch Weichert, my partner, and Li Wang did a very interesting study using Zmax. And here is one of the data points they showed. Let's take a 2.5 diopter toric IOL, which would be a T6 if you're talking Alcon. And let's tilt it. If it's tilted the normal 5 degrees, the amount of astigmatism that it induces is about 0.1 diopter. And it also depends on the power of the IOL, by the way. But if you tilt it 9 degrees, like one of those other eyes, it creates up to 0.6 diopters of astigmatism. And if the IOL is treating with the rule of astigmatism, so the IOL is lined up at 90, that means the power of the IOL is at 180. Because it's tilted, that power is increased, and you can get up to 0.6 diopters of extra correction. Whereas if the IOL is treating against the rule of astigmatism, so you're lining up the IOL here, that means the power of the IOL is here. The tilt will actually decrease, the tilt of the IOL will actually work against you, and you'll get an undercorrection. So this is another thing I think in the future we'll be thinking about. What about induced astigmatism? Well, I told you that 0.1 was our amount for clear cornea. Is that really the whole picture? And Jack Holliday and George Pettit published a very interesting paper that said surgically induced astigmatism seems to be actually greater, and it actually kind of underwrites or supports the Baylor nomogram. They think that there are other factors, maybe lens tilt, posterior corneal surgically induced astigmatism, that may contribute to it. So there's still things we need to learn about it. And finally, of course, one of the things that we struggle with is we got so much data to measure for each eye, and how do you bring it all together? I think we're going to go to automated systems that gather the data, pull the data into a program, and one of those is Veracity, and there are others in development. where you can import the refraction, the keratometry automatically. You can do the calculations are done. It tells you what IOL to put in, and all the data are presented. You can take that to the operating room. And so I think because of time limitations, I'll stop there, and I'll be happy to take questions.
Thank you very much, Dr. Koch. I mean, brilliant, brilliant. I'm sure that the 250 people that are watching us have learned a lot. I hope they learned as much as I did. It was brilliant. I did take some notes for our talk afterwards. So I think we should leave the questions for our interview at the end of the session.
Perfect.
So we can try to keep in time. And I have many questions for you. So I think we should move on with Bruna. So Bruna Ventura, she did her doctorate at Escola Paulista de Medicina, or Federal University of São Paulo. She did her fellowship with Dr. Douglas Koch in Houston. And nowadays, she's the coordinator of the specialization course in ophthalmology at the Altino Ventura Foundation, as well as the head of the cataract department at the same institution. Bruna has a very strong knowledge on biometry, not only on biometry. She's very active and very important person in our community nowadays. So we should welcome Bruna. And thank you very much for accepting our invitation, or Felipe's invitation. It is a pleasure having you here, and I would like you to begin your presentation.
Wonderful. Thank you so much for the kind words, Wallace. I always learn a lot when I'm with you guys, and I really thank you for the opportunity, for the invitation. It's such a pleasure to be here today speaking, and after Dr. Koch, it's a true gift for me. Thank you so much. I'm going to be presenting a case I'm going to be very objective for time reasons. So this is a 62-year-old woman that came to me. She was already a patient that was seen in the hospital, in our hospital. So I have her previous records, but she was for the first time in my office. So she came to me because she was referring a progressive decrease in vision in both eyes. She denied any previous diagnosis of ocular diseases. And in her electronic medical records, I could see that she was a year before, 2020, in both eyes with glasses. So when she came to me, she had in the exam 20/40 of best corrected vision in both eyes, a nuclear sclerosis of 2+, and the fundus exam within normal limits. Her pachymetry was 492 micron in her right eye and 490 in her left eye, a normal endothelial cell count, a macular OCT within normal limits. And she had this topography here. So when she did this topography, although she was over 60 years old and didn't have any diagnosis of previous ocular diseases, this topography showed that she had a corneal ectasia. And she had the diagnosis of two things. So she has keratoconus, she has cataract in both eyes. And it's very interesting the amount of patients that come to us that are over 50 or 60 years old and doesn't have the diagnosis of ectasia, but does have it in their eyes. So when we're with a patient that has cataract and keratoconus, Dr. Koch already mentioned about toric IOLs and when he indicates implanting toric IOLs, but we're always in doubt. Should we implant a lens that is a toric lens? Should we implant a lens that's a monofocal lens? So this is the moment where I'm thinking through which road I'm going to follow. And I follow most of the criteria that, like Dr. Koch mentioned. So here are, in a very summarized fashion, what I'm thinking when I'm deciding if I'm implanting a lens that's a toric lens or a monofocal lens in this eye. So four criteria would be contact lens independence to achieve best corrected visual acuity, mild to moderate ectasia, regular astigmatism in the central 3 mm zone, and repeatable corneal measurements. So we already saw from the previous slides that the patient was achieved her best corrected visual acuity in the past, in the very near past, like a year before she was with me, without depending on contact lenses. She never depended on contact lenses to achieve her best corrected visual acuity. She had a moderate ectasia, and she had regular astigmatism that we can see here in the topography in the right and in the left eye, how her central part of the cornea has a regular bow tie astigmatism, even though she has the corneal ectasia. With regards to the repeatable corneal measurements, she does have them. I'm going to show further ahead. So I decided on implanting a toric IOL in this patient, and then the next step is to decide which measurement to use when planning your toric IOL in these eyes. So here we see the IOL Master 700 data on the patient, her OPD scan, and the ISIS result for the right eye. And what we see is that with regards to the astigmatism, the IOL Master 700 measured -308 of astigmatism at 18 degrees, the OPD -3.56 at 18 degrees also, and the ISIS measured a much lower amount of astigmatism, so 2.6 of astigmatism, agreeing with regards to the meridian. When we went to the left eye, so the IOL Master 700 measured 4.13 diopters with the rule astigmatism. The OPD measured 4.25 with the rule astigmatism. And again, this is measured a much lower astigmatism, but agreeing with regards to the meridian. And it's interesting when we're looking at this data and we're comparing it with the patient's glasses. So she came to me wearing in her right eye +2 -275 at 20 degrees, and in her left eye +225 -4 at 160 degrees. So I have all this data that we measure, and this is my regular routine, let's say, when I'm having a patient that's planning for cataract surgery. So my routine is to get an IOL Master 700, an OPD, and an ISIS, sometimes also the Galilei measurement. And now deciding which measurement I'm going to take into consideration to do my actual toric calculation, I decided to go with the measurement obtained by the IOL Master 700. I easily excluded the measurement from the ISIS in both eyes because it measured a much lower amount of astigmatism than the other two devices that are in agreement with the glasses. And also based on the glasses that have with the rule astigmatism and a little bit lower than that measured by the IOL Master 700, that's how I decided to use the IOL Master 700 measurement instead of the OPD scan measurement. So I went ahead and I used the Barrett Toric calculator. That's the one that I routinely use. And in the right eye, I planned on implanting a 21 diopter VCT 300 lens, and in the left eye, a 20.5 diopter VCT 525. And after surgery, 1 month after surgery, she had uncorrected distance visual acuity of 20/20 in both eyes, a refraction in the right eye of plano -0.25 at 10 degrees, achieving a vision of 20/20, and in the left eye, she was plano. So just to wrap up, I always like to point out that in these cases of cataract and corneal ectasia, it's very, very important to explain to the patient what's ectasia. As I mentioned previously, it's not uncommon to have patients that have not had the diagnosis previously and that come to us thinking they only have cataract. It's very important for them to understand that the ectasia can influence the IOL calculation. So I showed an ectasia that's pretty straightforward with regards to implanting a toric lens. But sometimes when we have an ectasia that's more advanced or that has a more irregularity in the center of the cornea, but still regular, sometimes it influences the IOL calculation. So it's very important for the patient to know that besides having cataract, he or she has ectasia, which can influence the precision of his or her IOL calculation. if he or she has a visual limitation secondary to the ectasia that will persist after surgery. So that's very important to be explained also. And remember it's very important to remember to explain to the patient to avoid rubbing the eyes. Although our cataract population is much older than the population in which ectasia usually progresses, the fact of rubbing the eye is something that can make the ectasia to progress. So I wanted to finish here saying again to Dr. Koch, these are two very sentimental pictures for me. The one in the left was when I was living in Houston, and here's Marsha, Dr. Koch's wife, who a wonderful person that we love so much. Here we're having dinner with my parents, and this was before I was in my fellowship. I was about to start, the one on the right, and in the left I was already there. And I want to say here that it's such a privilege to have been with Dr. Koch for a year, learning from him not only ophthalmology, but also how to treat patients, how to treat the staff, and how to be a better human being. I'm sure I'm much better after I left Houston because I learned so much from him. So I thank Wallace very, very much, and Felipe for the opportunity to be here today presenting after Dr. Koch a case. Thank you so much.
Thank you, Bruna, for your excellent presentation. I would like to invite Dr. Koch for comments, please. Dr. Koch, I believe you're muted.
Yeah, there we go. Thanks, Bruna. Wonderful presentation. Just great hearing you and seeing that work. What a great result. Those are really challenging. I like the way you thought through it, that you used the glasses to sort of determine where you wanted to go, because I think that's one of those situations where the glasses can be very helpful, because these eyes with keratoconus, you don't know what the posterior corneal astigmatism is. And the only way you know it would be by guessing from the glasses. And so you very wisely chose that. And what a miracle you did for that patient. So I'm going to send every patient that has keratoconus for their surgery.
Please do. I love these patients. I love the ectasia patients. You can do it.
You know, the ones where you really are struggle are like that one image I show where they're so irregular, and yet the patient has it in the glasses and the measurements kind of line up. I think it's still good to use a toric lens, because that just means that their uncorrected vision will be somewhat improved, and you know, then the glasses are not as strong. There's not as much distortion. So even in some of the more severe cases, if you get some pretty good consistency, it's good. But when you I thought that was a great case.
Thank you. Thank you. Yeah, so it's very important for us to, when we're considering the expectations. So when we have a 4 diopter astigmatism in the glasses, if you promise that you're going to leave the patient with 0 astigmatism, it's much different than you're telling him or her, no, we're going to aim for leaving the least amount of astigmatism for you to have the best uncorrected vision you can, but maybe you're still wearing glasses. And then when you get a result that's 20/20 uncorrected, the patient, oh my gosh, you're the best doctor ever. So,
right.
Yeah.
And
I'd like to make a comment. You know, we are a little bit late. I'm not sure if Dr. Koch has seen it. I presented last year at American Academy a paper which Felipe Taguchi and Rafael Kobayashi are also co-authors. And we looked at 17,000 patients with keratoconus, analyzing the relation between the posterior and anterior surface of the cornea using Pentacam. And it was very, very clear that the highest the keratoconus indexes that we measured, the most different the correlation between anterior and posterior cornea from normal would be. So my question is, on those specific cases, should we try to measure posterior surface or should we try to infer it? Considering that Scheimpflug instruments normally don't do an excellent job in measuring posterior surfaces or of very aspheric corneas. What would be your input for the paper and also for the clinical cases that we face, Dr. Koch?
Well, yeah, I think you answered your question with your comment, because you know, it's just a challenge with shine fluid to get measurements that we can rely upon, and in these very irregular cases. And I'm, you know, quite honestly, even OCT, I'm not sure where we are yet with OCT in terms of accuracy and all these. I'm hoping that the IOL Master 700, the total keratometry, might give us an edge. But I think you're correct. I think there's a lot of guesswork about what the posterior cornea is. It's actually, to me, still kind of shocking that we can't measure it better. You know, optically, it ought to be the best with the Cassini if you have a lot of measurement points, like a topography, if you can measure a bunch of areas and get that, but that remains to be seen.
Great. Thank you, Bruna. Thank you, Dr. Koch and Dr. Wallace, for your comments. Let's move on. Next case will be presented by Dr. João Crispim. Also has been here with us before and studies a lot on this part of biometry. And he has some, Dr. Wallace always comments on his almost
May I comment on it, Felipe? May I? So, Dr. Koch, yeah. This is an interesting situation. So, João Crispim is very smart, and he was working on new landmarks for IOL calculation. And he had a great idea on measuring anterior and posterior surface of the crystalline lens and to position the IOL in the crystalline lens. So it was a completely new study. Nothing had been published so far about it. And he worked hard to have 30 patients operated, and we measured the position of the IOL after surgery and the crystalline lens before surgery. And he could calculate that IOL would stay on the 40% of the anterior length of the crystalline lens. And he was finishing his paper when Dr. Olsen published, I believe, 2,000 cases with exactly the same approach. So he was almost Dr. Olsen's first publication, right, Crispim?
Right, that's right, Wallace. Good morning, everyone. It's a big pleasure to be here today. I have a great affection of everybody in this department. I did my residency in Escola Paulista de Medicina and also my fellowship, and I learned a lot, like my personality, for everything that I do today here in Fortaleza. I think I give the credits, all the things that I learned with those guys, and it's a big honor to be here today. And it was very interesting, this research we did. Was Wallace's idea, of course, and I just did the hard work, but we still work on it, right, Wallace? We not give up. There's much more things to discover. So today I have this case of high myopia dilemma to present, and I don't have any disclosure to present. So this was a 54-year-old female teacher from Fortaleza, and she came to me with a severe difficult driving during night. Patient reports progressive worsening of visual acuity in both eyes, which greatly limits her daily activities, especially driving at night. She has a past ocular history of high myopia. She used to have glasses of around 12 to 14 degrees of myopia, and she was submitted to LASIK in both eyes about 18 years ago. And she had fibromyalgia for past medical history. During exam, her lesometer was around -4 in both eyes, with a -2 of stigmatism in the left eye, and her manifest refraction was a bit increase in myopia. In the right eye, we can see it was -5.5, and the left eye -5.75, and her visual acuity was 20/50 in the right and 20/40 in the left eye. During the slit lamp exam, it was clear to see a nuclear sclerosis, very central sclerosis, very similar in both eyes. The IOP was in regular measurements, and the fundus exam had this pathological degeneration, but the macula was okay, was fine. There's no heme, there's no scar in the macula. Okay, so the diagnosis of this patient was a high myopia in both eyes, the cataracts in both eyes, and the status post LASIK, myopic LASIK in both eyes. So I asked for topography, pachymetry, and biometry. The topography, we can see in both eyes there is a flat in the central flattening, considering of oblate cornea, very flat was for her past lesometry. The pachymetry was around 440, and in both eyes, specular microscope fine. High biometry, we can see that the axial length in the right eye was 31.58, and the case was very flat, around 36. And in the left eye was 32.1, and the case also around 36. And the diopter of the IOL, considering the SRKT and the SN60 IOL, was around 9 in the for emetropia, and in the right eye, in the left eye was 8.5. But the patient was a post-LASIK patient, so we did the biometry with a Higgs L myopic status, and then the biometry gave us a 13 and 12.5 with this axial length. So the question is, considering this patient with a high myopia, should we push in the brain to process? Because when do you need to adjust the axial length according to Wang and Koch, as we discussed during this meeting, that those extreme myopic patients have this extreme increased axial length. So we're gonna review the concepts. When you have this biometry in high myopia, the challenge is those axial length more than 25, 27, 27.45, they show us a hyperopic shift, a hyperopic error. Because, and there's some consideration about it. The optic biometry focal fixation is very poor on those myopic patients. The refractive index of the vitreous is different, considered different from those vitreous, pathologic vitreous in these long eyes. And it's very difficult to calculate the effective lens positions, that it's not predictable. So, but the reality is though that those high myopic patients nowadays, they are predicting a refractory result. So, and also we are having today these IOLs with power positive and negative powers, as MA60 with that range from +5 to -5 diopters. The options that we have today for high myopic patients is target for a moderate high residual myopia. So when you have this publication from the group of Walter Starr, Dr. Starr, we can see that axial length, and then we can measure, we can target for a little bit more myopic, depends of the axial length that we measure. As we see here, when we have those range, we target for this minus, and then after when you have more axial length, and then we want to increase the target, depends on the measurement. We have also the adjustment of the axial length according to Wang and Koch. There's a publication on GCRS, and there's the formula, depends on the use it. So the general formula was optimize the axial length you can measure, and then multiply for these numbers. There's a publication that Dr. Koch was the chief of the publication. And also the third option, we can use the Barrett University 2 formula. It's online, it's the free online formula, you can use it. But in case after refractive surgery, what to do? Should we adjust both cornea and the axial length? Because when you go for this patient here, the IOL power selection, when you see for no adjustment, you give us for the XN60 is in the right eye is around 9, the left eye 8.5 for SRKT. We only do the excellent adjustment when based on one Koch goes to 10.5, 10, but there's a post-refractive patient. So when you use a regular Haig's Ale from the IOL master for 500, we see 13 and 12.5. But do we need to combine those measurements? Do you need to adjust the axis length and do a post-refractive formula for both questions? Because when we do this, the IOL power would be in the right eye plus 15, and the left eye plus 14.5. So which IOL power should I select? And this is the question that we need to go there and study a little bit more. So when you go to the Dr. Hill website, there's a section there that I used to read this. I think I read this 4, 5, 6 times. And there's a topic about high to extreme excellent myopia. And they give very good thoughts, very good, or what we should do on those cases. And I'm sincerely talking about this. I used to read this and I never focus on that, because there's a note, a big note that mentioned this method for adjusting the axis length is not recommended for patients instead of prior refractive surgery, RK, LASIK, or PRK. So when you have those cases with extreme myopia and post-refractive corneal refractive surgery, is we go just recommended go to the ACRS formula calculator that's online, or we can use the Part 2K formula for myopic status, LASIK, and we can put the data there where you get the measurement from the IOL mask. And the IOL power suggests is around 13 is very compatible with the IXL formula. So when you go to just this and the post-refractive adjustment, we see 13 in the right and 12.5 in the left eye. I was very afraid about this case because I was in the questions what to do around 13 or 15. So the right eye, I decided to put a little bit more myopic because, as Dr. Koch said, those extreme myopic patients is very sad, is a great deception from them when they get hyperopic results. So I put in a little bit more myopic in the right eye first, and the treatment I did with SN60 was 13.5 and 12 after 2 weeks of the surgery, because the manufactured fraction on the right eye was -1 with 20/25 vision, and the left eye was plano with 20/25 vision, and the patient was very, very, very happy. So for this case, I have some topic and this dilemma that has high myopic patients. We can give some take-home message. In 4 points, we can show that we can say that if you have a high myopic patient, we can target for a moderate residual myopia. It's possible also to use the excellent according to Wang and Koch. Or you can, it's recommended also to use the Barrett University 2 formula. But remember, if we have those patients after refractive surgery, independent of the excellent, do not adjust the excellent instead of our prior RK, LASIK, and PRK, because on those patients, just go to post-refractive formulas only, and you're gonna get great results. Thank you, Taguchi. Thank you, Wallace. It was my pleasure, and I think I can contribute with this case. Okay, it was a great honor.
Thank you, Dr. João Crispim. I would like to ask Dr. Koch once again for comments, please.
Yeah, that's a great case, and of course I completely agree. And a couple of things I want to point out. With high myopes in general, the formulas that we're doing now, whether it's the Wang Koch or the Barrett or whatever, are getting more and more accurate. And one of the reasons is that in a high myope, the IOL power is so low that changes in the effective lens position have a relatively small effect on the postoperative outcome. So That's one of the great things about high myopes. Once we've got this axial length part solved, then our calculations can be really quite accurate. LASIK spoils all of that because notice this was a 31 millimeter eye, and yet the power of the IOL was 12 or 13 diopters. So now you're getting, sometimes in post-LASIK or post-RKIs, I'm putting a 25 diopter or 20 diopter. So now the problem about predicting effective lens position gets involved, and that makes it more challenging. To João's point, the reason we don't do axial length modifications in those post-refractive eyes is all of those formulas were developed without the axial length adjustment. All of those formulas, including the Barrett, took a group of patients, like the Hygas did the same. They took a group of patients, they did a bunch of calculations, and they said, oh, here's what we do to get good results in these patients. Well, that takes into account of the cornea, the back of the cornea, axial length, all kinds of things. So axial length adjustment is automatically folded into those formulas by the way they were developed, because they were developed on eyes where the axial length was not adjusted. So that's the explanation for it. So yeah, again, those were great results. Again, if you look at the literature, almost all of the data you see in the literature are reporting less than 80% with a half diopter. There are a few that are above, but most of them are 75 or even 70% best results. So we have even further to go on these eyes in order to get better results.
Great. Thank you once again. And now we'll have a section of questions and answers with Dr. Koch and Dr. Wallace Chamon. So, Dr. Wallace, if you would start.
First, I have to unmute. So first, it's all a pleasure. We were talking behind the scenes here that this whole setup is just we have the opportunity to chat with you, because this is what we like the most. And unfortunately, we don't have that many opportunities for that. But I did prepare some questions, and they were based on the questions that were sent to me during the week, and also some questions that were sent here in the chat. So I'd like first, I know that some of those points have been addressed in your talk, but I'd like to summarize it. So we know that nowadays many error in IOL calculations, they are a result of inadequate measurements of keratometry, axial length, anterior chamber depth, or whatever we use most, white-to-white, lens thickness, or whatever. So my question is, there are so many technologies nowadays. And my question is, would there be an ideal method for each measurement? So I'll start with the anterior case. We have Placido, Scheimpflug, and OCT. So how do you choose, or how do you evaluate each approach for measuring anterior keratometry?
Well, that's a great question. For the anterior cornea, I think that reflection technology is still the best. Whether it's Placido, and by the way, I always do Placido on my patients because of I can look at the Myers and I often can detect epithelial basement membrane, dry eye, and other things. But the LEDs from the LensStar, particularly the IOLmaster 700 now, I think are the best way because they give you very precise points, and reflection is the direct measurement of how that cornea is focusing or changing the light, whereas Scheimpflug and OCT are elevation-based measurements that have to be converted back. And so there's some limited accuracy. For the posterior cornea, well, all we have now are the elevation-based, which are Scheimpflug and OCT, and I think OCT will prove to be more accurate. And then this possibility that we can again get reflection through devices like the Cassini.
Okay, and for axial length, do you see differences in the different technologies or of OCT technologies?
You know, I don't really. The only advantage that I see with the lens, well, there are two things that I see as an advantage of the OCT for the Zeiss as opposed to the LensStar is you can visualize the B-scan. You can see where the gates are lined up very clearly. relative to the tissues that are being measured. And of course, the swept source OCT is so much more robust and dense cataracts, cataracts that I never could measure before. Now I can measure with the OCT. But in terms of axial length, optical low coherence reflectometry from the Lenstar and the IOL Master swept source, they're pretty similar. I think swept source is a little more accurate, but I'm not sure it makes a difference clinically.
And anterior chamber depth, we still have ultrasound, which were the original Huygens formula was based on, and Scheinpflug and OCT. Which one? How do you evaluate it for anterior chamber depth and lens thickness?
I think OCT is the winner there. I think it's more precise, and again, you also verify it visually much more easily than you can with a Lenstar.
Okay, so one more question. There are many. We'll make it a maximum of 20 minutes, so we don't spoil you much. So the question is, I know you have the paper and you presented it, the anterior axial length segmentation for OCT. And I remember that on your first papers, you didn't see a very high contribution for segmenting the anterior, the axial length. Did your conclusions change? How do you see it nowadays? Should we do it?
Well, I think it's good. The Barrett formula, if you compare it to the other formulas, it showed a bigger advantage. But for the Barrett formula, it didn't show that much advantage. And that's because the Barrett formula is, I'm sure it's just pages and pages of steps and formulas. And for different eye lengths, he's already kind of taken that into account. He's kind of adjusted that part of the eye calculation. He has an axial length modification in for long eyes after he saw our work on long eyes. So one of the great things about his formula is he continually adds things to it as new data are coming out. So, I think that you can get to where the Barrett formula is just without even any modification. But ultimately, I think it would really be nice for us to be able to do segmenting and do ray tracing. I think that's going to be the best way, but like I said, the effective lens position still is the problem.
So since you consider the length or the probable length of the Barrett's formula, I have a question that, it's very personal. How do you evaluate unpublished formulas? Do you have privileged information on how they work? Like, do Dr. Barrett tells you how the formula works? And do you feel comfortable using a formula based solely on its clinical results? Or you need to understand its rationale? Do you need to understand or to look at the formula before accepting it?
Well, that's an interesting question. Every formula a lot of formulas are published, exactly what they are. The Barrett is a mystery. It's a black box, mostly. The Hill RBF, we know how we developed the formula, but of course we don't know all the different points in the formula. And now we have another formula that's being talked about, the Kane formula. Jack Kane from Australia has published a number of papers on his formula, and he now has a keratoconus formula. If you go to his website, he has a formula for IOL power and keratoconus. And again, it's not exactly, he says it's based on both Virgin's, kind of the Virgin's formula, and artificial intelligence. Well, the Barrett really is that way too. It's Virgin's and artificial intelligence because he's modified it. It's not purely Virgin's. So there are mysteries in all the formulas, and my final decision is what works best. That's really what matters.
Since you approached keratoconus formula, the keratoconus or ectasia as Bruna presented, my question for you is, do you have any different approach? Because if you consider the keratoconus has an increased corneal sphericity, and again, different relation between anterior and posterior cornea, what do you think are the best practices regarding and which formulas to use on keratoconus? We've looked at that, and none of the formulas are very good. So we use the Barrett and the Holiday 2. The Holiday 2 is pretty good in there.
And we also know that patients end up hyperopic with keratoconus. So if they're up to about 49 diopters, I increase the IOL power by half diopter. If they're 49 to 54, I increase it by a diopter and a half. Above that, I may increase it 1.5 or 2 diopters to prevent hyperopia. The other thing we do is in selecting the IOL power, because there's usually so much negative asphericity in these corneas, we will go ahead and use an IOL spherical aberration so that the IOL has uniform power along the IOL, and with that irregular cone, you don't have some kind of misalignment of the asphericity of the IOL and the asphericity of the keratoconus. Whether that matters or not, I don't know. It just makes sense to me optically.
Would it make any sense for you to use like double K formulas?
Yeah, double K formulas, yes, absolutely would make sense. That would probably help. But it turns out we looked at that and it doesn't really help that much.
Okay.
We did better just by using just kind of a little. I could show the slide of what we've got.
Please.
But yeah, let me pull that up while you're asking another question. I can see if I can find that.
So there was one question in the chat: is what do you do with the patients, or someone asked us 20% of the patients that use the toric multifocal IOL, and turns out with a astigmatism between half and 1 diopter, and complains. What would you do on those patients?
So for residual refractive error in these patients, it really, the first thing you have to ask is the refractive error due to, sorry, let me just pulling up these slides. If they're coming. Here we go. Let me share my screen. So these are data that Sumitra Khandelwal in our group developed with data from our group, from Bob Sioni and from Rudy Knights in the Netherlands, in Maastricht. And if you look at this is the keratometry, and this is the refractive prediction error with the Holiday 1. And the Barrett also had big correction. You can see by the time they're a 52 diopter cornea, these patients are ending up +2. So we kind of use this graph, but that's a pretty crude way to do it, because again, you can see the scatter, particularly when you get up into that area. If you look in the up to about 50 diopters, the R squared for this regression line is pretty good. But if you look above 50 diopters, the R squared is very poor, so that there's very poor predictability with this kind of crude way that we're doing it. And again, that's why I'm sort of thinking ray tracing might be valuable. So,
and do you use SIMK on keratoconus, or what is your best approach?
I like to use SIMK, yes. So you get an average over the cornea that way, yeah.
Okay, so, let me see other questions that we have here.
I don't think I answered, but.
I don't remember, what was it? But I have another question here. You referred to tilt and astigmatism. And this is a very common question among ophthalmologists. And my question is, does tilt can cause coma? And can decentration cause astigmatism in an IOL?
Tilt definitely causes some coma, and decentration can also induce both coma and some astigmatism. Yep.
Okay.
Not a lot of astigmatism, but it definitely induces coma. Again, those are sort of arguments for using IOLs with 0 asphericity, because IOLs with 0 asphericity, as it turns out, are less, the quality of vision is less affected in those IOLs by either tilt or decentration.
So there's another question from the chat here. I'll just read it for you. In my clinic, I have a Galilei G6 and an IOL Master 502. And my results using K readings and IOL power are constantly better with IOL Master and Hygis than Barrett and Galilei using total corneal power or only anterior K readings. Do Dr. Bruna, Ventura and Dr. Koch agree with this? or must be my acquisition measures not ideal? It's a little complicated question.
That's a complicated question. Man, I don't know what Bruna would say. You know, we don't find the Galilei to be as accurate as the LEDs from the IOL Master. So I'm not surprised that the IOL Master does a better job. It's interesting that it does a better job with the Higas than, but I think it maybe shows you that the pseudo image from the Galilei is wonderful, but it takes a while to get that image, and the eye can dry out during that acquisition time, and that sometimes can affect the accuracy. And it doesn't take, in a group of patients, a few dry eyes in there that are more affected in a Galilei than they would be by an instantaneous measurement with the IOL Master for that to play a role. I don't know if Bruna has anything to add to that.
So there's one more question.
I agree with you. I agree with you, and I use the Galilei more to see if it agrees with the other measurements than to actually get its actual measurement to input in the calculator. Yeah. I also have better results with the other.
Okay, there's one more question. When using MA60MA lens, which is a meniscus lens, can I use the one Koch axial length correction? Or should I use the nominal IOL constant for that?
No, for that, you absolutely can use it. You can use the Wang Koch correction. It works very well for those lenses. You want to use the manufacturer's lens constant for that, though. You don't want to use the ULUB constant. So for the meniscus lenses, use the manufacturer's lens constant, not the ULUB, because with the ULUB it changes if it gets off.
Okay, we have 3 more minutes, and there was one question about IOL. I don't know if you feel comfortable about that, but if you have any thoughts on how far are we from post-op IOL femto titrating?
Well, you know, the clinical studies are just beginning on that. The company that's doing the clinical studies that's further along with it is called Perfect Lens, and I actually am on the scientific board for them. And they have shown in rabbits, when they implant an IOL and then they do the adjustment with a suction ring to hold the eye, they get incredibly accurate, precise corrections of vision of the refractive error. Up to 2 diopters, correct the astigmatism. Clinical trials are starting. We'll see what happens. I think it's a very exciting technology. It's an exciting technology for that. It's exciting. You can actually make IOLs with that. You could take a blank IOL and you could just make the lens inside it. But I think we have to be sure that the quality of vision is as good as the standard IOLs before we get into all that. But I think we will be changing lenses down the road. In the future, I think you'll see IOL companies making IOLs designed to be adjusted so that they're more readily adjustable. And I think that'll be an interesting process.
What do you think will prevail? The adjustable, post-operative adjustable, or the electronics, how do you call that? Dynamic IOLs?
I'm not sure what you mean by
that. I'm talking about the Google Alcon works on IOLs that can accommodate. So if they can accommodate, they can be tighter too.
Yeah, maybe. There's a lot to be done on those IOLs. A lot to be done before we know that they're really going to be those accommodating IOLs. There's a lot of work to be done on those. I'm also involved with that, and that we got a lot to learn on those.
Okay, so the first question that you said you may not have answered was how to approach patients that after toric, multifocal toric IOL still resembles of, they still complain of lower visual acuity. So you said the first thing is we have to see if the refraction is the problem, and then?
Yeah, you refract those patients, get the best refraction, you put it in their glasses, and find out if the capsule is clear and there's no cystoid macular edema. Find out if they're happy with the vision. If they are not happy with the vision and the eye is otherwise normal, then you probably have a problem with the IOL and the patient not liking the IOL. On the other hand, if you put it in their glasses and they're happy with it, great. If their spherical equivalent is around 0, I use relaxing incisions. I use them very frequently to reduce the astigmatism up to 1 to 1.5 diopters. On the other hand, if the IOL's rotated, you can rotate it. But if there's residual refractive error, then you're talking about doing some kind of corneal modification. Usually you can do LASIK or PRK, or if you live in Brazil, you can do an add-on lens. If it's a 1 or 2 diopters correction, you can just put that lens in there, but we don't have that choice in the United States.
Not yet. So I think, unfortunately, we have to finish. As I told Felipe before, we could be talking for 2 hours if we had the time of it. Unfortunately, we don't. So it's a pleasure having you here. I'm sure that our audience learned a lot from you. We can't thank you enough. But I promise you, as soon as this lockout ends, we will meet and we'll have a dinner together, and we invite all our colleagues and have some wine. Thank you very much. Felipe, you're going to do the closing words, please?
Sure. I'd also like to thank everyone here for attending this meeting, and especially, of course, Professor Koch and the other speakers as well, Dr. João Crispim and Dr. Bruna. Next week, it will be May 1st, so we won't have our weekly meetings, but on May 8th, we will be back, okay? And we'll be back with the University of South Carolina with Dr. Caroline Maya, all right? Well, in the name of the university as well, I'd like to congratulate Dr. Koch on having this willingness to share all his knowledge with us and with all our attendees. And we will do our best to answer the questions that were sent in chat that we couldn't have time to do it here. Thank you all, and stay safe in this lockdown. Thanks, and until our next meeting. Thank you all.
Thank you very much. What a pleasure. Thank you.
Thank you. Bye-bye.
Thank you so much. Bye.